This is a video on clinical prediction rules by Daniel Baker. To start, I'm going to be talking about the article Clinical Prediction Rules by Simon T. Adams and Stephen H. Levison. And in this article, Adams discusses the importance of clinical prediction rules and what they are. In clinical prediction rules, or CPRs as they are sometimes called, are tests and processes that have been made to help clinicians make decisions. And these tests combine the symptoms, patient characteristics, and investigation results to estimate an outcome's probability or to determine the treatment or intervention that is most likely to be effective in a given patient's situation. And these rules are used by doctors, nurses, athletic trainers, anyone who works in a clinical situation. And a CPR is determined to be effective if it has two of the following criteria. It needs to have high sensitivity and high specificity. And sensitivity is the proportion of patients that will have the outcome predicted by the CPR, whereas specificity is the proportion of patients that will not have the outcome. And generally, these are a trade-off between one another. If one has high sensitivity with low specificity, and this is shown in the figure to the left, which is a receiver operating characteristic curve, or ROC graph, which shows the trade-off between sensitivity and specificity. And as you can see, as specificity goes up on the right, sensitivity goes down, and vice versa. Now, in developing CPRs, there need to have four main steps. One, there's a development where we identify predictors from various studies. And then two, we need to validate the test in a different population to determine its reliability. Then three, we need to look at its impact analysis and see how useful it is in the amount of resources it saved, patient satisfaction, money or cost cut. And then four, it needs to be implemented and have a successful adoption in the clinical practice. So there are five main methods to develop clinical prediction rules and clinical prediction models. One are scoring systems, which are derived from univariate analyses. Two are prediction models based on multivariate analyses. Three, nomograms, then artificial neural networks, and classification and regression trees. Now, scoring systems are a type of method to develop CPRs, which look at a scoring system, and they looked at the final score, and that's used to indicate the likelihood of the outcome. So in this type of method, a number is given to a various system or symptom that a patient might have, and then this symptom is given a number, and then as long as any other factors that are relevant, and then the final score is added up, and that determines whether or not a patient will have the following outcome predicted by that CPR. Next, we have the multivariate analysis, which uses logistic reasoning to show the relation between the predictive factors and the outcome in an odds ratio. Next, we have nomograms, which use graphical calculating devices that calculate practical formulas to find the given outcome. And these are generally easier to use and in many cases more accurate than some of the other methods. And then next we have neural networks, which feed multiple sources of information from the patient into a software program, which then produces the output and the probability outcome that the clinician is looking for. And this does not always consider other causal relations that the clinician might pick up on because it's mostly computer generated, but it still is usually accurate most of the time. And then finally we have the classification and regression trees, or CARTs, which use non-parametric tests to evaluate data and divide into subgroups. And then these decision trees are easy to follow and understand, and then you follow the arrows to a directed outcome. But these can be less accurate than many of the other models. So some examples of these. To the left we have a decision tree with the flow of outcomes, and then we have the artificial neural network and the nomogram. And some advantages of the CPRs: they accommodate more factors than a clinician can, and they usually give the same result given the same data and is not variable like people, so they are sometimes more accurate than clinical judgment. And a good CPR will give the probability of certain diagnosis based on the athlete's symptoms, so this can help save the athlete money. It can stop them from going through unnecessary x-rays or CAT scans or anything like that. And athletic trainers can use these CPRs to determine if an injury or an illness that an athlete has needs to be looked at further when they enter the athletic training clinic, or they need to be referred, or if they can take care of it right there. So next I'm going to look at an example of a CPR called the Alvarado scale. And this is a 10-point clinical scoring system that was developed in the 1980s for diagnosis of acute appendicitis. And this is a scoring system that weighs the presence of the following systems with the acronym MANTRALS: migration of the pain to the right iliac fossa, anorexia, nausea and vomiting, tenderness in the right iliac fossa, rebound pain, elevated temperature or fever, leukocytosis, or shift of leukocytes to the left. So here we have a picture of the Alvarado scale, which, as I said before, shows different features. It teaches these features or symptoms and assigns a score. And then based on that score, it shows the predicted outcome as shown at the bottom of the picture. So if there's a score of 1 to 4, then you would discharge the patient because they probably don't have appendicitis. Score of 5 to 6, you'd observe them and look at them because there's a good chance that they might. And then 7 to 10, recommend that you go straight into surgery. And so now we're going to look at the sensitivity, specificity, and reliability of this scale. So at the cut point of score of 5, the Alvarado scale has a sensitivity of 99% overall, and then which is different for men, women, and children, and then a specificity of 43% overall. And then looking at the cut point of 7, it has a sensitivity of 82%, and then a specificity of 81%. So in general, at the cut point of 5, this is a very good sensitivity. In this case, it's supported to rule out appendicitis at the score of less than 5. You can discharge the patient. Looking at if the patient has a score of around 6 to 10 or above 7, you cannot necessarily rule in that the patient has appendicitis because the sensitivity is only about 82%, but then you can't rule out that they don't. So the specificity is about 81%. So in general, Alvarado scale is useful to determine if a patient does not have appendicitis if their score is around 5 or less, but if it's around 7 or 10, it's not as useful in determining if they should have surgery.